Hello, and thank you for joining us for Know Your Care, a conversation about sickle cell disease health brought to you by Voices of Winged Warriors. Please remember that this information is presented for educational purposes only and to give you a general understanding of specific medical conditions. This information is not to be construed as or to be used as a substitute for medical advice, diagnosis, or treatment. Please consult your personal physician, specialist, and/or other qualified provider for advice regarding your own care. Let's begin. I'd like to thank you for joining us today for Know Your Care with Voices of Winged Warriors. We have Nirmish Shah. Is that correct? Okay. And you are the associate professor with tenure in the Division of Hematology and the Division of Pediatric Hematology, Oncology at Duke University. So you're here to talk to us today about Duke University's health maintenance guidelines for adults with sickle cell. If you want to give us a little more about your background, your involvement with sickle cell, and why you think sickle cell is important and these guidelines recommendations are important for our audience.
Yeah, thank you. Thank you so much for having me have the opportunity to talk a little bit about our efforts here. So as a background for myself, I'm a medicine and pediatric trained hematologist. So I take care of both kids and adults with sickle cell disease. I'm what we call a lifespan hematologist. I really quite interested actually in the transition period, really trying to get our kids and adolescents and to be successfully moved to the adult world. And so I've been at Duke University just over 18 years now, and very excited and very lucky to have them really protect my time to really just focus on sickle cell, a little bit of thalassemia as well, but really has been a big part of what I do. In addition to seeing patients, I also have another hat I wear, which is the Director of Clinical Research and in benign hematology, and of course a focus on sickle cell. So I've been really kind of very much involved in pushing for finding new therapies and new options for patients over the years, but we have a long ways to go, but we are definitely moving in the right direction, and every step in the right direction is a good step for sure. So again, thanks for providing me this opportunity. And as just, to answer your last point, which is really just asking about these new guidelines, I think today and having the opportunity to talk about guidelines is really, I think, a good emphasis on the fact that we want everyone that is able to help care for patients with sickle cell disease to understand the complexity of the disease. There's a lot that we need to make sure that everyone knows, and part of that is just general healthcare guidelines. And so that was a lot of the efforts that we've put together many years ago, but continue to try and improve upon.
Well, thank you. I'm very appreciative of this. I stumbled across this several years ago, and I have actually met people who don't know that these recommendations exist. And I know that transition from pediatric to adult care is difficult in many, many instances. So certainly, whatever tools we can find to help people take better care of themselves and take good care of themselves, we're very appreciative of those tools in the community. So I'm going to put the recommendations up on the screen, and we're going to start walking through what it is that you recommend. And I want to start with the point of primary care physician and hematologist as part of the care team, and why you feel it's important for individuals to have both of these medical professionals working with them.
Yeah, it's a really great emphasis point. So at its core, we can make all these recommendations of different aspects, which of course we'll dive into. But at its core is you need to have someone really kind of steering the ship, a captain. And in a way, the hematologist has done a lot of that. But I think what these recommendations have kind of put forth is that we want care to be both a primary care doctor, thinking about your general needs from a day-to-day basis, as well as our general care, let's say it be hypertension or screening for diabetes. Your general care really still should be followed by a primary care doctor. But you have, with a patient who has sickle cell disease, there's a lot of unique aspects in regards to sickle cell. And so there is overlap for sure. And very much what I see in my clinic is I have grown to build a good relationship with my patients. And they tell me straight up, they're like, Dr. Shah, do I need to go see my primary care doctor? You've known me for so many years. And my short answer is yes. The longer answer is, my goal is to be there as a resource for your primary care doctor, but I don't expect them, being the primary care doctor, to take care of sickle cell. That's what I'm for. But the primary care doctor is also going to be there so that if I have questions about, let's say, again, diabetes or something else that is a general medical condition, then there may be some aspects of sickle cell may complicate or have some things that we need to consider in regards to that. Again, I keep using diabetes as an example. It's just any other complication. But we need to work together, and I want them to be more up to date, and we'll be able to drive that part of the conversation. So yes, I think it's extremely important to have both a primary care doctor and a hematologist working together so that we can make sure that every aspect of any medical issue that comes up can be addressed.
So we're going to circle back to the diabetes point in just a moment, but for those patients who don't have access to both of these providers, let's say the patient only has a primary care provider, what's the best way for that individual to work with their PCP to ensure that their sickle cell care needs are met?
Yeah, again, a really good emphasis point here, because it is, again, as I said many times, a hematologist or a primary care doctor is doing most of the care. Realistically are many patients who live out in the community and just don't have access to a hematologist as quickly or as easily as their primary care doctor, which is local to them. And what I would encourage in both situations is if you have one person that you trust and that you feel like is an easier access point, talk to them about finding the other person in this network that can be the kind of counterpart to you. So if it's a primary care doctor, find the hematologist that's nearby that they can refer you to so that you can start seeing them for part of your care. Now, again, it's a shared ability to take care of you as a patient. So if it is that, and I do this quite a bit, if there's a situation where the patient lives 2.5 hours away, we recognize as a hematologist that we can't have you coming so frequently for 2.5 hour drives both ways. When a primary care doctor can do some of that, meaning some of the labs, some of the intermittent discussions, but the sickle cell actual specific conversations about, let's say, a medication like hydroxyurea or some other sickle cell specific conversation, that's going to be driven by me. That would be something that I would definitely, and I'm sure that both of us respect the importance of each of us being in there. So what I would say is encourage you to talk to either your primary care doctor or your hematologist to make sure you link each other and find, and each of us have those networks. I am absolutely sure that the primary care doctors know how to make a referral to Duke, for example, for me, or to the regional sickle cell center so that they can have the, and I'm absolutely sure that they would be encouraging of that, just as I would be encouraging of my patients finding a primary care doctor as well.
Thank you for that. So we're going to circle back very quickly to the diabetes topic that you brought up. Know that there are many tests that your primary care physician runs, as you said, for your general overall care that your hematologist doesn't necessarily run. And one of those that has come up in several recent conversations in the community is A1C tests. And there, people are wanting a little bit of clarity around what A1C tests should look for or look like for individuals with sickle cell and individuals with sickle cell trait. Are there differences, or is there something specific or different that individuals should be looking for with A1C tests, let's say?
Yeah, absolutely. So a great opportunity to have a patient advocate for themselves. So it should be known, and but it's not always known that A1C, meaning it should be known by the medical team, the providers, that A1C is a reflection of sugar over time, like your glucose levels over time. And so it's a better reflection as opposed to me just checking your random blood sugar at any moment because maybe you just had a piece of candy before we did the blood test. But an A1C is a reflection of how much blood sugar is actually bound to your hemoglobin. And so it usually is a reflection because hemoglobin for someone who doesn't have sickle cell has a lifespan of about 90 days. And so it really is a better reflection of how much your blood sugar has been over the lifespan of that red blood cell. The issue that comes about with sickle cell is that that lifespan of red blood cell is much shorter. And in fact, it is about 10 to 20 days. So really not necessarily a great reflection of what your blood sugar has been over the long period. It's a fair assessment, but definitely can have inaccuracies from the shorter lifespan, as well as the sickle cell itself is misshapen and the hemoglobin therefore can cause some inaccuracy. So what that means is more so for sickle cell patients who have sickle cell disease, sickle cell anemia with hemolysis, but also potentially for sickle cell trait, is just to recognize that it may potentially be inaccurate. So it can actually underestimate the blood sugar and so miss some cases. So I would say there are other tests that you can consider. There's one, you don't have to remember all these details, but there's one called fructosamine. There's a glucose tolerance test. There's all kinds of other tests that will give you the same kind of answer. But what I would encourage our patients to really be focused on is just know that an A1C may not be perfectly accurate and it may require additional testing. If there's ever questions or concerns, ask your doctor. Again, your doctor should know, but I would say, again, for sure, a hematologist would know, but a primary care doctor may not think about it first, maybe not be the first thing to their head to think, oh yeah, that's right. With sickle cell disease, your red blood cell doesn't have the same lifespan, and so maybe we need to do an additional test. So the additional tests are not complicated either. It's just maybe having in the back of your mind. So it is a great opportunity for our patients to really speak up and say, oh, by the way, I appreciate you doing this test to look for diabetes. Is that accurate? Are you sure? Is there another test that might make us all feel better that that's not a situation, especially if diabetes runs in the family and there's some concern? Stopping at the A1C is for sure not necessarily the answer, but I think it's all about asking the questions and at least having it in the back of your mind.
Well, thank you for that clarification. I think people will find that very helpful. So, as we talk about that clarification and self advocacy, we're going to dive into the recommendations as they're presented. And we'll just go in
Mhm.
order, like I said, as they're presented. So, we'll start at the top with utilization. What is the importance of this particular section of the recommendations, which touches on ED visits and, your specialist visits and things like that? What's the importance of that being included in these recommendations?
Yeah, so I think that the first two parts to this, and by all means, this is not necessarily the order of the discussion when you come in to see the patient, right? I mean, it's not that the first thing you walk into the door and you see your patient, you're trying to catch up on how things are going in school, at work, et cetera, that you have to start talking about pain and utilization. But one big aspect to really just understand how well your patient is doing is just to know, did your patient that you hadn't seen in a certain period of time have any significant issues that led to them not being able to control their pain at home? We know that most of our patients try and do a pretty good job of trying to manage their pain at home because patients don't want to go to the hospital. They don't want to go to the ER. They want to be functional and do what they can. So they'll make it work. So they do a fair job of trying to manage their pain at home, but it's not always enough. And so in both aspects, if the pain is not able to be managed at home and they have to go to the ER, or for sure if they're hospitalized, I as a physician need to know that so I can figure out what was going on that led to that. Is there something underlying that I need to try and do better evaluation of? An example here is there avascular necrosis or something that's underlying that's causing repeated pain? Or is the pain strategy not necessarily the best? I mean, meaning we haven't figured out the best pain strategy to help my patient do well at home so that they can get good pain relief and not go to the emergency room. So that's why we're trying to emphasize asking, and I would go maybe one step further and not just asking about pain and how many times you've been to the ER, but one very common question that I try to ask is I get a little bit of questioning around what they've been doing to stay busy, what are the things that they've been doing around the house, and things that keep them moving through the day, and then try to get an understanding of, are they able to do those things? So if they can't get to school, if they can't wash the dishes, they can't, walk the neighborhood like they used to, something's changed, and I need to understand what's making those limitations occur so that, again, I can readdress what can I do to hopefully get my patient better.
I appreciate that, both from a clinical point of view, and I met someone recently who wasn't familiar with these recommendations and also made the comment that it was new to them because they felt like their hematologist always took care of everything, right? So they just kind of go to the visit, and whatever the hematologist does or whatever their primary care physician does, they assume that everything's being taken care of. So when you talk
Sure.
about self-advocacy, the importance of the patient also knowing what should be happening, and how can that help improve a patient's care.
Yeah, I completely agree that self-advocacy, and I think part of this is my mindset is really, I think, driven into this, into the importance of this, because I see a lot of teenagers, they're trying to become independent, trying to understand their disease, trying to understand how they fit into the world with a diagnosis of sickle cell. And a huge part of that is having them speak up, really having them not just have mom and dad do all the decision making, answer all the questions in clinic, give them all the medications. I start that transition discussion at age 12 to 13, but pretty quickly I start putting my hand up to mom, and I'm like, no disrespect, but I need to hear it from them. I need them to speak up, and part of that is having them start asking questions and starting having the patient themselves understand, what is it that is different that maybe needs to be addressed with my physician. And so I almost always make it a point to say, well, what questions do you have for me? I want you to ask me questions. And so I really try to push that concept early, because I agree with you. Self-advocacy is a huge part in a disease that's not always well understood when you go to the emergency room, and the nurses and the physicians may not have the same level of comfort, depending on who you get. Of course, there are some great nurses and physicians in the emergency room, but sometimes you get some that have less experience, and that's where having the patients advocate for themselves and know their disease and know what needs to be followed becomes very, very helpful.
I think it's also notable in the recommendations that you list out, touching on several different types of pain, acute or chronic, priapism, what pain medications an individual is taking, if they have a pain provider separately, things like that. Because I feel like as a caregiver, I can remember my son just kind of, you know, taking some of this as run of the mill, right? So he might not bring up the fact that he's having additional daily pain because he's used to having pain. And so he's not going to mention it at a physician's office. So I think that listing out these various topics to touch on is also a good way of reminding folks to bring up all the things that you may take for granted or you may have normalized in your day-to-day life, but they still should be brought to the attention of your provider.
Yeah, and I think it highlights also, I think it's a good opportunity to bring up that we have under pain here this pain agreement plan or an individualized pain plan. And I think that's every patient should have an individualized pain plan. And what I would encourage is not just to have it, but to have it readdressed. That's the first part. Make sure it's readdressed annually. Every year we should be thinking through, has this changed? Is there any other aspects that need to be refined? And then secondly, making sure that the patient themselves are not only aware of what the pain action plan is, but having them have input into it. I think we encourage patients to be able to talk to their providers and make sure that we're all on the same page. That again, we feel like this is what's worked in the past, and this is why we put this in place. But if it's not working, how can we make sure, again, we strike that balance of helping you when you're in acute pain, but also if, for example, you have a history of chronic pain, that I'm not making chronic pain worse as well. So we really want to make sure we're addressing every patient individually. And so a patient should be able to pull up their individualized pain plan. And if we're following it and it's something that you've had a discussion with your hematologist or your pain doctor with, then we're all on the same page. And I think it leads to better care in these acute settings.
I think we can have an entire side session on the pain agreement plan. But if you could very
Yes.
quickly, for people who don't have a pain plan, or you hear a lot about you should have a pain plan. I think a lot of people don't know what should go into a pain plan. Can you kind of give that, kind of give us an outline
Yeah.
of what that pain plan should look like?
Sure, sure. So the first is to make sure that there's an assessment of how you're doing as a patient. So we put standard recommendations of trying to make sure that we're not missing something really worrisome. And the first thing that always comes to mind is making sure that we're not missing something like acute chest syndrome, right? If you're having breathing difficulty, if you're having a pneumonia, you're having something like acute chest, then we need to work very rapidly as well as control the pain, because the pain leads to you not taking good deep breaths, which makes things even worse. So it's a combination in those settings that we really have to be actually more aggressive with pain control when you have acute chest in the hospital, actually, because I need to monitor you and watch you closely. But if you have those type of general, let's say, lab testing that you need to do, clinical assessments, looking at your vital signs, the next most important part is to recognize, well, what are the pain treatment strategies for you? And so the first starts with, are there specific medications that I need to give you? And so it starts with non-opioid type medications like anti-inflammatories, if that's appropriate. And let's say, for example, if you have kidney damage, I wouldn't want to do that. That's why an individual documentation of this is very, very key. And then if there are opioids, there are different types of opioids, and should it be IV, which is usually what's given, but there are occasions that sometimes we do just oral, and so there are very specific plans put in. Usually it's an IV dosing where they give you doses within certain time periods. Again, they map out, every so many minutes in the beginning, and then we space it out. We put you on a PCA pump, which is basically a patient-controlled analgesia. The patient now is able to have a continuous rate and a button to try and give additional doses. But all of that is individualized and should be something based on what you got the last time you were in the hospital. And you look back at those records and you see, did this work for the patient? And so we want to make sure that those type of things are put into the documentation. And that's where you have acute type of treatment plans, you have inpatient treatment plans, and then you even have guidance for, as you get ready for this patient to be discharged, are there potential suggestions here? Should we make sure that who's going to be filling out those prescriptions? Because we don't want to just discharge a patient and not have a plan of who's going to help get you those pain medications upon discharge. So we want to make sure all that's mapped out, all within this individualized pain plan.
And I think that helps bring together the different components of these recommendations, because as you're talking about developing an individualized pain plan, certainly utilization is going to come into that. How did your last ER visit go, and maybe what pain treatments did you receive and did they work for you? And I can see how that can impact your individualized pain plan, as well as the next section of the recommendations, history. I feel like history is one of those, excuse me, things we feel like we all repeat over and over and over again. But again, the history, things may change, things may evolve, and that could ultimately affect your pain plan, right? And any revisions to your pain plan. So certainly, if you can speak to, what people sometimes find annoying, that being asked again and again and again for your history and why that is so important to keep that updated at each visit.
Yeah, and I sometimes almost come into the room, and again, my goal is to have the patient prove to me that they know as much as they can about their disease. And so I ask a ton of questions. And so I think my patients kind of gotten used to that. I know, for example, that they're on hydroxyurea. If they're on hydroxyurea, I know that. But I have them prove to me that they know the name of that drug, which is hydroxyurea. I have them prove to me that they know the dosage and how many doses they're taking or maybe missing. So, it's just really just having patients understand that our job is to really get them to, again, empower themselves to show that they know what they need to know, but also give us those key points of information to know if there's something else I need to look into. For example, on the list here is shortness of breath. You would be surprised if you ask patients more and more, well, when you walk around the neighborhood, can you keep up with your friends? When you're playing basketball, do you get short of breath? And if there is, then I need to understand more about that. I don't want there to be any reasons for a patient not to get enough oxygen. And so you have to ask these type of questions frequently. So it's all about just asking questions. And so I will go head to toe and ask all kinds of questions to get a better reflection of, am I missing something? And if I'm not missing something, that's great. But I have to ask it for me to understand that's indeed what's happening.
Well, I love the contextual framing of, for example, shortness of breath and how that may be impacting your activities and putting it in that particular context and reference, because otherwise people may think that their normal shortness of breath is just normal, right? But if you put it in the context of, can you do the things that you want to do or do some things better than other, I think that's one of those ways that helps history make sense when you're giving your history. The other
Yeah.
piece that I notice in particular is the depression screen as well, being included at each visit and not, I think my kids span 13 years and I've seen care change over the years. And it used to just be an annual assessment for each of them, but including it at each visit. What's the importance of asking that question at every visit?
Yeah, so I think it highlights two things here. One is that depression, anxiety, mental health is not only situational, but it varies just from day to day and to what's happening in a patient's life as things are evolving. So that's the first part of recognizing that as the things change, you need to ask these types of questions with every visit so that you can quickly try to address if that's something that you're concerned about. And so in our intake form by our nurses are the first to start that conversation and do a PHQ-2, just very simple questions. And then you can start very quickly getting to, what are potentially the causes of those types of mental health issues that might be going on. The second thing is to recognize that, yes, it's situational and it can vary from day to day and visit to visit, but overall, in sickle cell disease, there's a high rate of mental health issues that we need to make sure we're addressing. Anxiety, depression, PTSD, post-traumatic stress disorder from not being able to anticipate when they're going to have pain is extremely stressful. So all of this leads to just making sure that we're having these type of assessments. And I actually try to layer this on added to the pain conversation. So whenever pain starts to become an issue, there's a lot of correlation between mental health and pain as well. And it's not that depression is causing pain or pain is causing depression necessarily. They can coexist. But I bring up the conversation with my patients as in one way to say, when you have pain, and especially when you have chronic pain, the brain is the central place that interprets what pain means to you. And the reason that strategies that are not just pain medications, let's say mindfulness, meditation, cognitive behavioral therapy, all these other strategies that are not medications work is because you're basically training your brain to interpret the pain in a different way so that it's more manageable, to more allowing you to be still functional despite that your body is feeling or experiencing this pain, but your brain is able to. And so another person that helps you regulate that gate to your brain is a psychologist or potentially even a psychiatrist if needed. And your mental health has a lot to do with how that gate is working to allow those pain interpretation fibers to come in and then change how you do from day to day. So I introduced that conversation fairly early so that patients understand that mental health is extremely important, especially when pain's involved, but also just as a whole with sickle cell disease. So I think it's an important topic that we need to address with every visit to make sure we're not forgetting.
I appreciate that. We're going to segue from that mental conversation to some very physical assessment components of the recommendations. Again, I appreciate from a caregiver perspective of many of these things being listed out because I feel like, maybe your PCP might do some of these, or maybe your hematologist might do some of these. But as I look at them, we're talking vision, spleen, liver and gallbladder, hip, knee, shoulder pain, which I would interpret as joint pain perhaps, or leg ulcers, and ear, nose, and throat, and dental care, and an EKG. Those are things that I feel like individuals might skip over at one physician and only do at the other physician. But I like seeing that each visit, these things should be addressed, the physicality, and then specifically as they relate to sickle cell. And so I think also listing out the guidance that's specific to these pieces with sickle cell. So, for example, how might your liver and gallbladder physical assessment differ in an individual with sickle cell than another patient, and why should I
Yeah.
heighten that assessment, perhaps?
Yeah, so I think the liver and the gallbladder in particular, the liver and the gallbladder are where your body is taking the breakdown of red blood cells and basically packaging it up and getting rid of it. So the gallbladder normally is used to kind of store things that help you digest food. But let's say your red blood cells are being destroyed because of sickle cell, and that's when you have this increase in bilirubin in your blood. That's where you see your eyes get a little bit yellow. You can see your urine becoming a little bit dark. But that bilirubin has to be packaged and gotten rid of, and the way that does that is through the liver and through the gallbladder, and then you excrete it. But the issue that can come about is that when you have a lot of bilirubin, you can form gallstones. You can actually form stones that become problematic. If your liver is doing a lot of filtering and not doing it necessarily as effectively or well, or you have iron overload, or you have fibrosis, or you have other complications, and your liver can actually grow in size a little bit too. So us doing an exam is making sure your liver is not enlarged, making sure you don't have pain over the gallbladder. Those are types of assessments that we do on the exam. And in a similar fashion, we try to go, again, top to bottom just to make sure we're not missing something. The shoulders and hips in particular, we're just trying to make sure that we don't have signs of avascular necrosis. You have a ball and socket joint in in your shoulders and hips. And when it's nice and smooth, everything moves very nicely on movement when I'm examining you. If you do have developing or even significant avascular necrosis for sure, then that smooth lining of that ball and socket joint is now not going to be smooth. It's going to be rough, and it's going to grind, and it's going to hurt when I'm doing the exam. So that's something that we can elicit, we can cause on the exam, because we want to know if that's something I need to worry about, because maybe I need to do a picture, maybe I do an X-ray or an MRI or whatever that helps me get a little bit more information about that. So that's where these exam listings here are just trying to kind of highlight that. There are some parts that are a little bit more specific. For example, the vision test should happen once a year, at least once a year. And I tell my patients, you need to walk out of that eye doctor with those funny glasses because they dilated your eyes and looked for sickle cell issues. The EKG we do for anyone who's on methadone, which is a long-acting pain medication. And methadone, if you're on that, has the risk of potentially causing some EKG changes. So we want to make sure we check that once a year. So there's some that are very specific, but in general, every time you see me, I need to be thinking about making sure I don't miss anything again. I want to make sure I'm being as thorough as possible.
Are there other reasons that an individual might need an EKG? Is that something that might be
Yeah,
emergency specific, or is that part of the annual physical exam for all individuals, or really just on a case by case as necessary kind of basis?
yeah, I would say yeah, I wouldn't say it's universally needed for every patient every year. That I definitely don't think is necessary. But I would say if a patient comes to the emergency room, has chest pain, sure, I think we want to make sure it's not the heart. So we want to do an EKG in that setting. If a patient's short of breath, for example, or there are settings even as an outpatient, if there's concern about pulmonary hypertension or cardiac concern in that regard, that might potentially lead to us needing to do an EKG. An EKG is really just looking at the voltage going through the heart. And so it's best to pick up arrhythmias, meaning the heart's beating a little bit funny or beating too slow, or there's a rhythm disturbance, because it's just looking at the voltage through the heart. It's not looking at structural issues. That's where an echocardiogram or ultrasound of the heart, looking at the pumping, is better. And that's actually definitely better to look at backflow. So if you're looking at pulmonary hypertension, we're looking at backflow. There's too much pressure on one side of the system versus the other. And that's where an echocardiogram comes in place versus an EKG, which is literally just putting all those leads across your chest and your arms and your legs and just looking at the rhythm. But so it is case by case, but those are some of the scenarios.
Is there a need, or is it helpful to have either an EKG or an echocardiogram as a baseline as you move into adult care at all?
Yeah, so the recommendations aren't there that it's required as a baseline as of yet. I think I'm pausing because it used to be that the guidelines change over time, but it used to be many years ago that we did a lot of different tests, let's say pulmonary function test, echocardiogram, 6-minute walk test, treadmill test, all kinds of stuff, almost like a baseline, but we weren't getting a lot of valuable information with that. And actually, we didn't even know what to do with some of that information. So now we've changed it to go back to a lot of what you're bringing up today, is if the symptoms are there, if we ask questions and you start to mention, oh, by the way, I am short of breath when I walk, or I do have some issues with my heart, feeling funny, or this or that, whatever the symptoms are, then I might do some of these testing at baseline, but also kind of follow over time. So it's now more symptom-based in regards to shortness of breath and some of that workup. But we don't necessarily do them just as a baseline, based on the consensus so far.
Okay, thank you for that. I want to dive really quickly into the lab section in terms of just defining some of these labs for individuals, because you do list out the intervals that these labs are recommended for, but I think people may not understand what some of these cover. So we'll just start with
Sure.
CBC with retic. What does that
Yeah.
mean for people?
Yeah, so that's a complete blood count with a reticulocyte count. So that complete blood count is when we look at your hemoglobin, your white blood cells, your platelets. What we want to see is that your hemoglobin is staying stable and it's definitely not dropping. We want to make sure that your white cells, which often in sickle cell disease are a little bit elevated, we want to make sure it's not elevated beyond your baseline. So if it is usually elevated, that's okay as long as it's stable. And then same thing with platelets. Platelets are often a little bit elevated, but we don't want it to be exceedingly high. A A retic count is basically your body's way of making kind of like early blood. So it's just a sign that your body's really trying to kick out blood from your bone marrow. So it's a good sign that your bone marrow is really trying hard. The concern would be, let's say your hemoglobin is low and your retic is low. That means your bone marrow and your body's not really making enough blood. Then that's probably why your hemoglobin is low, because it's not able to keep up. You know, you're destroying the blood, but you're not making enough. So those go together, and we want to check those at least, with twice a year. But for patients on hydroxyurea, for example, that's actually how I make sure I monitor the effectiveness of hydroxyurea. I monitor if I need to go up in the dose in hydroxyurea. So every visit, basically about every 3 months that we usually see patients on hydroxyurea, at a minimum, we should be checking the blood counts too.
Okay. So ferritin, what do ferritin labs do?
Yeah, ferritin it's an iron, it's a reflection of your iron stores. So it's actually important. You know, there's a misunderstanding sometimes by non-sickle cell specialists, but sometimes that when you're anemic, because your hemoglobin's low, and you have sickle cell, they're like, oh, your hemoglobin's low, you just need some iron. Here's an iron pill. That's absolutely not what you're supposed to do. You can be iron deficient, and we do see some young females who are menstruating who can become iron deficient. That's technically true. But more commonly, iron is actually too high. So what happens in sickle cell is that patients with sickle cell have a low hemoglobin, and their body feels like they need iron, so they're just trying to eat up iron as much as possible. And so then if you give them iron, they're actually going to get too high on iron. So they're not iron deficient. They're just low in hemoglobin because they're destroying their blood because they have sickle cell. And so ferritin is a reflection of what the iron stores are. So if I just do a regular iron level, it's what the iron is in the blood that day. And the ferritin is what the iron is in the bone marrow. Like it's a reflection of what's being stored. And so it's a better accurate number to follow. And so I check the ferritin values at least once a year. Getting a blood transfusion, there's a lot of blood and iron in blood transfusions. So if you're getting several transfusions in a year, that would be enough to get your iron levels almost too high. So that's why we want to make sure we're watching it every year to make sure it doesn't get too high, and I need to consider, do I need to do something about it?
Okay. So for T, Billy, and LDH, what are those measures
Yeah,
used for?
yeah. Yes, the bilirubin, the total bilirubin, and the lactate dehydrogenase, LDH. All you need to know for both of these is it's a sign of hemolysis, a sign of destruction of your red blood cells. They're going to be a little bit elevated in sickle cell disease. Usually it's elevated. Again, I want them to be stable. As long as they're not getting elevated beyond what they usually are, then I'm usually okay. But I would advocate, as I say, for each of these labs, know your labs. If you have access, I tell all my patients in clinic, you have access to your chart. We have Epic here at Duke, so I say, do you have access to my chart? Most of my patients now, because I say this all the time, they say, yes, I do, Dr. Shah. And so we actually pull up their labs on their phone while we're in clinic and like, look, this is what your normal is. This is where you run. Because having patients, again, be empowered by knowing their own labs then allows them to see a lab that's not normal for them and ask me questions about it, but also drives the conversation of what I should do about it. And probably most importantly, if they happen, for any reason, happen to go to the emergency room, they can say, even if the ER physician says, well, you have sickle cell, your hemoglobin's 6, that's fine. They can say, no, but I went through this with Dr. Shah, and my normal is normally 9, and now you're telling me it's 6. And I know I have sickle cell, but that's not normal for me. And so I think that's where having a patient know their normals is really important. That for all these markers here, the CBC with retic, the ferritin, the hemolysis markers, total bilirubin, LDH. The next numbers are the liver numbers, so AST, ALT, those are the liver numbers. And the last thing you have here listed under labs is looking at the urine analysis. And I think it's an important part because probably about 40% of patients with sickle cell will have some evidence of kidney damage. And how do we measure kidney damage? And this is a common question that comes up, is that, we can look at the lab values. There's one called creatinine, which is just a gross value. In sickle cell, it's actually sometimes on the low side because it's being what we call hyperfiltrated. Your kidneys are kind of working overtime. But the function of the kidneys is very well measured by looking at how well it filters things. And one thing it filters is your proteins. If you think about it, you want to hold on to your protein. You don't want to spill your protein out. And so we can look at what's called microalbumin or even albumin. Microalbumin is small albumin, right? So small albumin, and we do microalbumin levels. And if you're spilling microalbumin, that means your filter is not working well. Your kidneys are not holding your protein in. That's an issue. That means your kidneys are not as working as perfectly as possible. So that's why at least once a year, we want to make sure your kidneys are filtering properly. And it's for good reason, because not only do we want to follow that, but there's actually a medication that can actually tighten that filter up a little bit. And we need to get you to the kidney doctor. We need to do some follow-up. So that's what all these labs are and why it's important to follow them.
A quick question on the urine piece. You're looking at an annual interval to be following that, but what are some things that people might need to look for at home that might cause them to bring this to the attention of their provider? Like, what kind of changes might people see in their urine at home that they should say, I might want to call my doctor about this?
Yeah, I mean, I think the quick answer is that anything that seems concerning. I'm never opposed to having a patient ask questions. So if something's changed in their urine, then ask a question. Of course, if you see blood, that's definitely alarming, and you need to let someone know. But let's say your urine is always very clear and dilute, and now it's very dark, and that's new for you. Then you need to let somebody know. If you start to notice that your urine is very frothy and there's a lot of froth to it, which is not normal, again, it's a change. If something's changing, I would encourage you to ask your physician. It's sometimes kind of hard I want to say sometimes, it's technically really hard to know that you're spilling small amounts of protein, so you may not even pick up on it, which is why we make it an annual assessment. We just check it, even if you don't feel or know or notice anything, just because we want to make sure we pick up on it early. But I would encourage you, if you have issues, to just ask questions, and we can check the urine for sure.
Okay. I want to dive into just the last one of the pieces under the health maintenance is vaccinations. And you've got a couple that
Mm-hmm.
are recommended here, but in light of everything that's happening in the public health sphere right
Yeah.
now, what are some of the, where should people be going to look for credible vaccine information these days? And, if they want some background, if they have some questions, what are some of
Yeah.
the places that people can go to these days?
Yeah, so I think this is a great opportunity to highlight that the trust you have with your primary care doctor and your hematologist is probably one of the biggest aspects of providing you with all the information you need to make a good decision here. Vaccines, I think we've been using for many, many years, and there's a wealth of data to show what the benefits can be from vaccinations. And so in sickle cell disease, for sure, there's an increased risk of infection, and for sure early in life. And so we have it here on health maintenance. The PCN stands for penicillin. And so we use penicillin at birth because we know that the risk of infection, and actually the mortality, the deaths that we saw decades ago now, were really driven by infections early in life. And now that we use vaccinations and penicillin, we actually don't have that mortality risk. We don't have that early death rate that we used to see. And so it's a big deal that we use vaccinations and use penicillin early in life. But to answer your question, the sources, I think, come now to the internal medicine and the Academy of Pediatrics still have guidelines making standard recommendations for when and how to get those vaccines. And most notably, for sickle cell disease, the spleen which all patients have when they're first born, it becomes not as functional as they get older. And the spleen helps fight a specific type of bacteria, a specific type of infection. And we call them encapsulated organisms, but basically just means it's a specific kind of bacteria. And that includes Haemophilus influenza B, pneumococcal infections, and meningococcal infections. And those three right there have very good vaccines. And so because the spleen is a big issue within sickle cell, you got to get those vaccines. Now, all the other vaccines, are all mapped out, but those are all vaccines you get early in life and then need to be readdressed as you get older. So that's what we're starting to make sure it's highlighted here in this consensus statement. But I would encourage you to talk to your primary care doctor and your hematologist. And what we're using is the standard recommendations that on the pediatric side, the AAP, on the adult side, the American College of Internal Medicine. They have standard recommendations that we still follow.
Hey, well, is there anything that, we feel that you want to emphasize or that you feel we may have overlooked in our conversation today?
Yeah, first I want to thank you so much for bringing some attention to the guidelines that we think are the start of trying to make sure we recognize that there's a lot of aspects that we need to make sure we cover with our patients, but also to recognize that we need patients to be advocating for themselves, and patients and families should know these details too. I did want to just maybe throw in there that we are continuing to revise and update and provide more details for these kind of guidelines. And this was our effort here in North Carolina and at Duke to have our first effort. As you mentioned, it's been a little while since we this was 2014. It seems like time flies. But there was the National Alliance of Sickle Cell Centers, NASAC, had just put together and just published. I was just at the hematology meeting last week. And they are now highlighting different aspects of what the consensus is. And they basically went through 41 adult and pediatric providers, some of which that did both, like myself, and asked, what are standard guidelines? And they pretty much match what we have here. But they even have some, additional insights, such as the transition program, like what is it that qualifies as a successful movement from peds to adults. And so I think we're still trying to set the bar really high, which I think is appropriate. We want to make sure we do as good a job as we can, but to the highest standard. And so I just want to highlight that we are continuing in this NASAC, or National Alliance of Sickle Cell Centers, is another effort just recently within this last 6 months or so to try and put out more and more recommendations of how to be fully encompassing of all the things that we just talked about.
Well, thank you. So I'm really excited that you were able to join us today and share this information with individuals. I want to remind our audience that this is available on our website at www.sicklecellstat.org. We also have the pain algorithm, which is referenced in these recommendations, and emergency room guidelines from the American Society of Hematology and the American College of Emergency Physicians. And I'm sure we'll be revisiting this information again in the future. Thank you again for your time today. Thank you for tuning in to Know Your Care with Voices of Winged Warriors. Voices of Winged Warriors exist to help save lives. We provide awareness and education around mental wellness and health maintenance for grievers and warriors. We also provide and promote emergency treatment tools that change care and that help save lives. To learn more, visit our website at www.sicklecellvow.org, or for information on emergency sickle cell care, visit www.sicklecellstat.org.